Hello and welcome to our virtual rhinoplasty meetings. My name is Dr Cameron McIntosh and I'm the president of SORSSA, or the Society of Rhinoplasty Surgeons of South Africa. So during the coronavirus lockdown period, we decided to have bi-weekly Zoom meetings. We specifically chose teachers from around the world to be able to cover many topics. Unfortunately, due to patient confidentiality, we can't actually show you the real talks. However, the very interesting interactive question and answer sessions is what we're going to be showing you. We want to give a shout out to our colleagues around the world fighting coronavirus. Please look after yourselves and be safe. So I'm not going to say anything more. Enjoy the show. Episode 7, we've moved all the way down to Colombia to listen to Roxana Cobo speaking to us about the thick-skinned rhinoplasty patient.
Fantastic. Roxana, thank you so much for that. It was, I found it fascinating because we have a lot of thick-skinned patients in Africa as well. I've got lots of questions, but I'm going to hold my questions and go to the questions that have been asked. Please feel free to write any questions, and we're going to see if we can get through those. Let me just open up the chat, and then I'm going to start asking you questions. So lots of well done, good to see you. Here's a question for you from Nkenseni actually. Hi Roxana, thanks for the presentation. If you want to reduce bulk on the tip, won't using the flap be counterproductive?
Yeah, I learned this the hard way. The SMAS, the superiorly pediculated SMAS flap, I do not use in type 3 patients. The ones that have the overly thick skin, that flap is not good. So what I do in those patients is I resect the SMAS, I elevate the skin as if I were making my SMAS flap, and I basically resect all that, and I use that as a graft. And that helps me because it helps you, one can use it in the nasal tip as a graft. It helps you get a little bit more tip definition points. I also use it a lot in the radix as a radix graft. And the other place where I use that SMAS, if I'm going to use it as a graft, is in the nasolabial angle. And it works very nicely. It helps you push out this area here in a very subtle, soft fashion. And it works beautifully.
Awesome. Thank you. Okay, so here's a question. Dear Roxana, great presentation and I like your philosophy. One question, please. After 6 months post-surgery on isotretinoin, do most patients stop? If they stop, is there a relapse gradually over the next year or so in skin quality and nasal definition as the skin gradually reverts? Thank you.
Okay, I'm gonna answer this way. If younger patients, at least in Colombia, we don't have a ban on drinking, okay? People here drink, I don't know, they start drinking when they're 16, I think. So the big question with the younger people is, are you kidding me? I'm not gonna be able to party and I'm not gonna be able to get drunk because I'm taking isotretinoin. You're crazy, I'm not gonna do it. So what I tell them is, and I know this is not, there's an off-label use for this, but I tell them, look, you're taking 2 tablets a week, 3 tablets a week at the most. If you're gonna go to a party, go to the party. Don't get drunk, try not to get drunk, but it doesn't matter. What do I tell responsible younger patients? And I know I shouldn't be saying this, but ideally, alcohol is the big no for younger patients. So younger patients use isotretinoin until their skin gets nice. When their skin gets cleared up, they stop it. But if they relapse, and sometimes they do a relapse, they immediately know they can start it again. And they call me and they tell me, look, I've got acne flare-ups again. Can I start the isotretinoin? Of course you can start it. And if all of their lab work is okay, I'll restart them on that. And I'll go a little bit more. I took isotretinoin, I don't know, maybe 10 years ago. And the dermatologist is a good close friend of mine, and that's the reason why I started using this. I've been using isotretinoin for a long time, and I take 10 milligrams a week. And it's beautiful for the skin. It makes your skin beautiful. So you don't really need to stop it unless you have a hepatic function problem or anything like that. But I mean, it really makes your skin look nicer. And I mean, it's not going to make me look a lot younger, but it does make my skin look nicer. And patients tell me all the time. They come into my office and they tell me, oh, you have beautiful skin. I say, of course, my products. They make your skin beautiful.
That's awesome. That's awesome. I also just want to remind you that this lecture, you can apply for CME points by going on the link that Harry sent through on a message to everybody. So I'm going to carry on with another question here. Sure, there are lots and lots of questions coming through here. It says here, is not the SMAS flap blunting tip definition?
I don't, in type 1 and type 2, I don't think so. And there's something that I have seen over time, and maybe I should have shown it. But what I have seen, I've used, when I trained with Calvin Johnson, I spent a year in New Orleans. So when I got back to Colombia and I started working, I would use shield graft in every single one of my patients. And I just want to make a comment, because in Colombia, I trained in the endonasal approach. And what we do here, many of our surgeons do here, is a reductive rhinoplasty. And so I went to Calvin, and Calvin was open, and he would use a lot of grafts, and he would use a shield graft in every single one of his patients. So I got back home and I started using shield grafts. And so now I have 20, 25-year follow-ups with shield grafts. And I'll tell you something, my experience with a shield graft is that no matter, I mean, the skin has to be a type 3 skin for results not to show over time. Because what happens with aging is that skin starts thinning out over time. So basically, what this flap does, it basically hides any irregularities or any angles that you end up creating without wanting to when you place sutures or when you place tip grafts. You know, those things over time become noticeable. And I've got follow-up on patients, and I'm like going, oh my God, we don't have thin skin patients in Colombia. I shouldn't be getting these. And they thin out, and they thin out because they're getting older. And so my experience with the SMAS flap, and I've been using this almost, I don't know, 4 years, 5 years now. So far, it has been great. The noses look very nice. Type 3 patients, no. They look very round, so it's not good. I stopped using them in type 3 patients.
Awesome. Thank you. Question here is, what is your antibiotic prophylaxis protocol for thick skin patients with rib grafts?
Okay. Thick skin patients with rib grafts. I don't have a special protocol, and I'll tell you why. Because I don't leave the drains. Dean does, but then I don't do as many dramatic cases as Dean does. Basically, what I do is I use a Cypro solution during surgery, and I basically put the graft inside the Cypro solution, and then we basically periodically irrigate the nose with the Cypro solution. And what I do routinely in all of my rhinoplasty patients is that we use dacitracin ointment, and I start them on that a few days before surgery, and I tell them to start using that inside their nostrils, and I use that after surgery also, at least for 2 weeks. And it has really helped me because it really diminishes the scabs and the crust formation inside the nose. And the other thing is, I don't usually pack my noses. The only thing I do, and I didn't have the video to show it, but then Rod Rorik spoke about it, is I do use silastic sheeting on the ala, basically to reduce the dead space in this area. And I don't use the big ones that Rod uses. I basically take one of those nasal splints that come like in 2, and then I cut it, and then one is for one side, the other one is for the other side, and I basically cut this in half. One goes inside the nose, the other one goes here. And what is important though is that when you're tying, and this I learned from Dean, when you're tying the knot, I basically put a mosquito clamp underneath the knot, and then I tie over it, so that way it's relatively loose, so that when this swells up, it basically, you won't end up with skin necrosis. And then the other thing I use is that I use I don't use Surgicel, and the reason I don't use Surgicel inside the nose is basically because in Colombia it's damn expensive. So I use gel foam, and I use a little piece of gel foam in here on each side, and that basically helps me keep the contour. And the rest of the gel foam, I basically use a piece on top of the dorsum to help me eliminate the dead space. And on top of that, I put my tapes.
Awesome. Awesome. Okay, similar two questions here. First, have you ever had a skin necrosis?
No. I saw skin necrosis with Calvin, and that's one of the reasons why I don't use cautery in the nose if I don't have to. I've had skin sloughing in one patient where I used the silastic sheeting, and it heals. It heals well. You have to leave it. I mean, you cannot touch it, and it heals well, and the scar eventually goes away. But I've never really had any skin necrosis. I'm very careful with my flaps. And with the SMOS flap, I've never had a skin necrosis, and I knock on wood. Never, ever.
Okay, now a question on the flap there. It says, does the flap dissection lead to severe edema post-operative as it damages venous drainage? What is your view?
No. No, I could be mistaken, but honestly, I don't think it makes my noses bigger. Why? Basically because I'm obsessive with the ice. So my patients come out of surgery and their head is elevated, and it has to be elevated at least 45 degrees. If I can do it 90, it's 90. And they need to sleep that way the next 5 days. And then the ice, and this, I once heard Enrico uses this ice mask, Enrico Robotti, which I thought was amazing. It's incredible. What I use is the Colombian version of that. I basically tell them they need to ice their face constantly. So it's ice here, 20 minutes, they rest, 20 minutes, they rest, and this has to go on the first 72 hours, day and night if possible. And so if you do that and you change their diet, the inflammation really goes down. And then when I see a lot of it, it's basically the patients that get more inflammation are the patients that are acne prone. And those patients basically benefit with the isotretinoin. That really helps the swelling dramatically.
Yeah. Okay, thank you. Ted wants to know, are you worried derotating the tip with a SMAS flap?
Do I what? Excuse me?
Aren't you worried that you will derotate the tip with a SMAS flap?
No, never. Never. Never, because the SMAS flap, what it does is that it basically brings everything, it covers my whole tip. It is not under pressure. If it's under pressure, then I'm in trouble. It's a covering, it's a flap. So I use it basically to cover. I'm not using it to make, and so since the hinge is up here, right here in the super tip, and the way I mark this is, I don't know if you see, well, my freckle is down here, but basically I do this, and right here is the super tip. So I mark this, and this is the way I extend my dissection. So if I'm extending my dissection up to here, when I pull it down, this is basically coming down here. And then what I do is I put a piece of gel foam right here, and then I put tape right here. So that really brings me down. I don't need to do more pressure than that. I don't need more.
Awesome. Ali Rez, Ms. Boy's got a great question or comment here. He says, I think taping of nose after rhinoplasty in thick skin patient is very important. I tell my patients to tape their nose at least during the night for 2 to 3 months after surgery. What do you think, Roxana?
I tell them they're crazy. And I'm sorry, Ali Rez, I know a lot of people, most of my colleagues do it. But what I tell my patients is, after 2 weeks, I want you no tapes for 2 reasons. One, because patients who are a little bit cuckoo need to organize their mental image of their new nose. Here Tom is saying they need to have a drink, obviously. But you know, they look at themselves in the mirror. They see that they're swollen. And then they start, you know, and they start covering their nose with tapes. And I frequently see patients that have been using tapes years. And you're like going, no, wait a minute. You need to create the new image of the new you with your new nose. It's going to be swollen, but it's going to come down. So those patients, I don't tape them. What I do is I start them on a skin regime, and that skin regime really starts working on their skin. And since the skin doesn't really break out too much, it starts thinning out with the isotretinoin. I haven't used tapes for over 2 weeks, and I would say at least 15 years. And I haven't seen the need of having my patients tape their noses at night. Now, there's one thing you do have to tell your patients. If they lay down in bed completely horizontal, when they wake up, if they're swelling, they might swell up a little bit initially, the first months. So they wake up in the morning and they see their nose, and their nose is huge. But that, over the day, as the day goes on, that swelling goes down. And you need to tell them that. You need to explain to them what's going to happen. And they'll understand. Most of them understand. And you need to tell them it's at least, in thick-skinned patients, between 12 to 18 months.
Awesome. Okay, here's another question. Thanks for the nice presentation. I think the best way to deal with thick-skinned tip is dome division. What is your opinion?
I don't do dome division. I was educated in a school that used to do dome division, but I see a lot of sequela with dome division. And the reason for that is, and remember the blanket that's covering the dress that's covering the nose. I mean, our dress, the blanket that our patients have, is very thick and it's very heavy. When you do dome division, that's going to buckle sooner or later. And our patients, usually patients that have very thick skin, I know Turkish patients tend to have big cartilages, but our Latin patients tend to have very flimsy cartilages. So if you do a dome division there, the possibilities that that's going to buckle is 100%. So definitely no, I don't ever do a dome division. What I do, if I have a very long lateral cartilage or medial cartilage, is that I do an overlap technique. So I do a lateral curl overlay or I do a medial curl overlay. But I never take out anything in the nose. I usually try and use my cartilages as autographs. I do turn and flaps, but I don't usually resect too much in the nose.
Okay, great. Okay, we've got a question all the way from Greece, from George. He says, great presentation, Roxana. Question number 1, do you ever remove skin wedges?
Yeah, I do. And the reason why I didn't include that here was because of time. And not only do I do alar-based resection, but that I leave for the end, and I'm very conservative. What am I doing today? And those patients that have very thick, and that's almost like for a different talk. You know, it's almost a talk on its own. But patients that have very thick, round ala, what I'm doing today is I'm being even a little bit more aggressive. I'm going all the way, not up here, but I go back, because what I want to do is, this is a little bit too similar to what Hossam Fora does. So it's not only in here, I go out here because you want to reduce, you want to diminish this length. And the only way you can really do that is by going outside and basically making the whole ala smaller. But yeah, I do that, but I don't do it routinely. My philosophy is that I'd rather have a base that's a little bit wide than to have a base that is overly closed, because that you cannot fix. That's very hard to fix. If you have an alar base that after the surgery the tip has lost some projection or whatever, my tips usually do not lose projection because I'm using septal extension grafts. When I was using struts, they would lose a little bit of projection. With the septal extension graft, where the tips, where I end the surgery, that's where the tip is going to be there a year later, 2 years later, 10 years later. So I know that. So if I can do tensioning, this usually diminishes this width. So I don't need to do as much alar wedge resection.
Okay, awesome.
Now, black patients, yes.
George had a second question there. He said, do you use sutures to close dead space? And if so, where do you place them?
Sometimes I use one suture, the same suture Maman uses, and I learned it from him, right here in the super tip. And for me, it's easy because since I elevate the flap and I go right there, there's usually a little bit of extra tissue there. So I basically take a little piece of tissue inside here and I put it and I fix it to the anterior septal angle. Now, you need to remember something. When you do structure rhinoplasty and when you do structuring in the nasal tip, your anterior septal angle, I mean, that area changes completely. It changes dramatically. So you can mark it and maybe it's down here, but after surgery, maybe you don't want it down here. Maybe you want it a little bit further back. So I mark that at the end of surgery. I define exactly where I want to place the suture as I place it. But since I use the SMOS flap a lot, and then I use gel foam on top of the skin, and then on top of that, I use tapes, that usually helps me eliminate the dead space. And that's the only suture I use. And then the other thing I do, and that is me, is, and there's some studies I use for the skin, 6-0 fast absorbing, 6-0 fast absorbing Vicryl. I'm not using permanent sutures anymore here.
Okay.
And the scar is just as good.
Sure. Okay, I can ask you another question from Alex. Can you perform the SMAS flap in secondary rhinoplasty?
That's a good question. That's an excellent question. I have tried. It's very difficult. It's very difficult because usually what happens in primary rhinoplasty is that the people elevate the flap. And if there's, for example, what people routinely do, at least where in my country, is the intercrural ligaments, any of that tissue between the medial crural, they basically take it out and they throw it away. So when you go back in there, it's going to be very difficult to really create a flap. What you end up having is a lot of scar tissue, depending on how many revisions that patient has had. And what I do is, many times I use that scar tissue almost like a graft. So I don't dissect unless I have to. Sometimes the scar tissue is so fixed to the cartilage that it's almost better to just basically leave it and construct on top of that. So it's very hard to elevate a SMAS flap in revision patients. Very, very hard. I've tried. It's very difficult.
I've got another question here about the flap. It says, what is the extension of the flap? Does it cross in the direction of the dorsal pocket?
Well, it's right here. And it comes down here. So that could be what, 1-2 centimeters? Depends where you start dissecting. I usually start why? Because that's an area where usually you have a lot of growth and thick skin patients. So that's tissue that we usually take out. What I do is that I dissect it and block, and that I use at the end. So when I put my flap down, sometimes there's a little bit of tissue left down here. So I basically cut that, and that I use as a graft somewhere else, either in the radius or in the nasolabial angle or whatever. So I start down here.
Okay, well, Roxana, I think we've kind of run out of time now. There are a few more questions that unfortunately we can't get around to. Let me just grab one last question here. What is your view on thinning of the tip flap?
I'll tell you what I think. I don't like thinning on the tip flap. I showed you SMOS resection. I use it only in type 3 patients. I tell them they're going to scar more. Why? Why don't I like it? Basically, there's going to be a lot more edema. That is a fact. 2, one cannot really completely control the scarring. So if you do not elevate uniformly, and sometimes it can be hard to elevate uniformly, you can end up with indentations more on one side and on the other, or more scars on one side than on the other. So it's not uniform. So what I do, if I can, is basically only in the type 3 patients, I resect the SMOS and the fibrofatty tissue, and then the rest I basically do with isotretinoin orally. And it works much, much nicer. It's more predictable, I think.
Wow.
And
Well,
one,
Roxana,
one last thing, sorry, Cameron. Don't use cautery when you're resecting this mouse, because if you use cautery in the dermis, you could end up with necrosis. And I've seen people use cautery there, and that really freaks me out.
Yeah, sure. Wow. Well, I'm so sorry to have to cut the meeting short and end it. It's been absolutely fantastic. I really, really appreciate you taking time to help us with SORSSA and all the people around the world who are listening. This international journey of ours is taking us back across the Atlantic to Turkey on Thursday. We've got Prof. Faisal speaking to us on reconstructing the nasal dorsum after hump resection. But I really appreciate you taking your time, and thank you so much for everything that you've done, and a huge congratulations from all of us.